Dr. Alok Gupta, welcome.
Namaste, Shashi and Anup, and Namaste, India.
Namaste, sir. Namaste. Yeah.
So the viewers, welcome to India's second Metabolic Health Conference. Of course, you know my name. My name is Shashi. I'm a metabolic health coach and a member of DLife.in, India's oldest, biggest, and the only award-winning low-carb platform. So along with me, there's Anup Singh. So me and Anup Singh, we both bring to you this historic and scientific feast from India. The metabolic therapies is the name of this specific conference. So let us invite our special guest, Dr. Alok Gupta. He's an Indian, but he's from Australia now. Dr. Alok Gupta, welcome.
Thank you,
Welcome, sir.
Anup ji and
Welcome, sir.
Shashi ji for giving
So
an
you can
opportunity.
call me
So
Anup.
you,
No need for G.
you can call me Anup and Shashi. No more G. So
Uh,
I'll take the pleasure in introducing Dr. Alok Gupta first. Dr. Alok Gupta is a nephrologist with 20 years of experience in treating a wide range of both acute and chronic renal conditions. Originally from New Delhi, Dr. Alok received training in general medicine and advanced training in nephrology. He then went to complete a 2 year clinical fellowship of nephrology at Toronto, Canada. Upon his arrival in Australia, he practiced at Bildura Base Hospital in the regional Victoria. In 2015, he was awarded his fellowship in medicine nephrology by the Royal Australasian College of Physicians. He moved to Toowoomba, regional Queensland in early 2016, and since then has been practicing in public and private sectors. His practice is permanently based in Toowoomba. His area of clinical interest lies in metabolic syndrome and its management through lifestyle changes and medication, both into resistant hypertension, CKD, and associated complication, as well as renal stone disease. So we today have the pleasure of having a nephrologist coming to us and speaking on CKD. Dr. Alok Gupta, thank you again for this session. So I will just ask a very basic question on what is the prevalence of CKD globally, and what are the main reason for so many people developing CKD?
yeah, so Shashi, the CKD and its prevalence is growing with period of time because the risk factor for CKD, like aging, type 2 diabetes, metabolic syndrome, hypertension, obesity, is also growing. As per a statement in 2021, which was a joint declaration by American Society of Nephrology, International Society of Nephrology, and European Renal Association, these are three large, very prominent bodies in the field of nephrology. The prevalence of CKD in 2021 was about 850 million people across the world. Now, this is double the number of prevalence of diabetes and 20 times the number of patients suffering from cancer. So you can understand the range and the magnitude of involvement of kidneys due to growing risk factors, which I just mentioned: obesity, metabolic syndrome, type 2 diabetes, and hypertension. And CKD accounts for about 1.2 million deaths every year. And if you account for the cardiovascular deaths associated with CKD, the number goes to about 2.6 million deaths every year.
Huge. Anup?
Yeah. So why does uncontrolled blood pressure and blood sugar causes kidney damage?
So let's deal with diabetes first. So traditional view and teaching has been, or traditional, I would say, narrative has been that it's the high glucose levels which has a downstream effect on kidneys. We are born with usually two kidneys, though 1 in 500 can be born with one single kidney. And each kidney has about 1 million units, which is about 10 lakh in Indian terms. So 10 lakh units in each kidneys. After the age of 35, we tend to lose some of the kidney function. So just to explain, these nephrons, they are individual units, 1 million in each kidney. But each nephron has a head called as nephron. It's the nephron, the nephron is the individual unit, and the head of the nephron is called as glomerulus. Now, this is the glomerulus where the blood comes in and gets filtered downwards and ultimately makes the urine. So if you look at a nephron, the filtration is called as GFR, so glomerular filtration rate, and which is how we measure any kidney function. Now, the glucose causes hyperfiltration in these nephrons. So the nephrons start overworking. So initial stage of diabetic nephropathy or diabetes-related chronic kidney disease, your markers of kidney functions are actually better because these kidneys are overworking hyperfiltration. That's the first stage of diabetes and diabetic kidney disease. And if you miss them around that stage, then the kidney function deteriorates very quickly from there on. So these nephrons are overworking and hyperfiltrating. So if you're overworking and stressed, some of the older ones or sick nephrons, they die. When these nephrons die, they pass on the work to the remaining nephrons. So the rest of the remaining nephrons are now overloaded with work. And this is a continuous job. So some nephrons die, they pass on the work to remaining nephrons, increasing the stress on the remaining nephrons, we eventually die. We call it hyperfiltration injury. Secondly, glucose itself can stick to the tissues in a non-enzymatic way. And we call it advanced glycation end products, or AGE. So it's like a Browning reaction or Maillard reaction. That damages the kidney. Number three, glucose, when it's metabolized by mitochondria, which is present ubiquitously everywhere in all cells, including kidney cells, it causes oxidative injury. There's a lot of glucose load, and the mitochondria has to process this glucose load. So whenever you process this, you have oxidative injury, like reactive oxygen species are related. So these are the major mechanisms how glucose affects the kidney function to start with. This is the traditional narrative. But there was a experimental study published in 2010. And one of the authors was Dr. Sue Coggin. She has been a past president of American Society of Nephrology. And I had the fortune to work with her for a few months while I was in Toronto, not in the research capacity, but as a clinician. So what they did was so insulin receptors are seen in all cells of the body, including kidney cells. So they made a hybridized rat or mice, and they knocked out that insulin receptor. So these rats were born with 90% of the receptors only in kidney were gone. So the insulin level go up because insulin can't work. Insulin is necessary for kidney nephron action. So these patients were insulin resistant, but mentioned they were normoglycemic. They were not diabetic. So high insulin at 5 weeks, they found these rats have leakage of protein in the urine. And 8 weeks, full-blown diabetic nephropathy without hyperglycemia. In clinical practice, I see it all the time, patients coming with pre-diabetes or features of metabolic syndrome and have proteinuria and features of diabetic nephropathy without being declared as a diabetic or even pre-diabetic. As Dr. Robert was saying, the microvascular complication starts at A1C of 5.5. All the three microvascular complications, including neuropathy, nephropathy, and retinopathy. By the time they turn diabetic, it's already too late. So insulin and glucose are both essential. Hyperglycemia and hyperinsulin both are essential to cause kidney damage. Coming to the hypertension, so high blood pressures can damage blood vessels. Kidney is the largest bed for small vessels, which we call as microvasculature. And due to this injury, there is hyperfiltration within the kidneys and subsequent damage. High blood pressure also damages the blood vessel across the body, including your brain, heart, peripheral arteries, causing increased risk of cardiovascular diseases. For a long time, the narrative has been the hypertension is essential hypertension or primary hypertension, which means we did not know what caused hypertension. But there is no doubt in my mind, it's part of metabolic syndrome. And it's the insulin resistance which manifests as hypertension in some of the population with or without diabetes.
Very
Yeah, I would
important
like
statement.
to extend on to your this hyperinsulinemia. I mean, high insulin, high blood glucose, or high insulin, normal glucose can also cause kidney damage. Now, in humans, what level of insulin do you consider as safe? I mean, this is just a follow-up question to your answer.
Okay. So insulin has been widely studied, but it's not commonly practiced. Usually what we do is we do a fasting glucose, a postprandial glucose, or an A1C. I think it's not practiced very commonly to do insulin levels, although I do insulin levels. As per the experts, a cutoff of about 5 to 6 international units of insulin is probably safe and normal. Anything higher than this could reflect insulin resistance. However, some patients can have a normal fasting insulin, but they have an exponential rise in insulin post glucose loading or post meal. So doing a HOMA-IR test, which involved an insulin and fasting glucose, is probably a better way to judge insulin resistance. But there would be some patients who would be still missed if you just do fasting insulin and glucose. And some patients, Dr. Kraft, he published his data and he was doing this insulin levels every hour for 5 hours. And he showed the response of insulin and divided patients based on their insulin response. But even if you do 2-hour GTT test with 0, 1, and 2 hour, you can pick the remaining group of patients which could be missed by just checking fasting insulin and glucose.
Okay, so we wanted to hear that number, because we also we also sort of say 6 is the cutoff mark, but we wanted this number to come from our doctor. Now, moving on to next question. Yeah, please carry on.
Sorry, but the lab which reports even here, I live in Queensland province of Australia. So there are 3 labs. And all the 3 labs have different normal range of insulin, and it could vary anywhere between 5 to 20. But you have to understand, they pick up this normal range for normal population. So they do a sample across the normal population, which is considered normal healthy. And that's how they pick up this range. But overall, the obesity in Australia, obesity overweight among adults is about 70%. So the insulin level of the population is going up. So it's very hard to define normal and healthy. But this is a general consensus among experts that fasting insulin about 5 to 6 is probably normal.
Now, you're a nephrologist, so how come this therapeutic carbohydrate restriction or low carb, interests you?
Yeah.
For your patients.
So majority of patients of chronic kidney disease, which I see, they suffer from metabolic syndrome. 40 to 50% patients have diabetes. Good 30% have hypertension. And either 10% is obesity. So if you combine all these 3 entities, which are part of metabolic syndrome, it covers 80% of the patients. So what I was looking at my practice late 2018 and 19, despite putting them on all possible pharmaceutical agents which were available to us and following all the guidelines, all my patients were worsening. I could slow down their progression, but I could not stop the progression of the chronic kidney disease. And most of patients will end up with on dialysis. A small minority of CKD population lands on dialysis, but majority die of cardiovascular causes. So in 2018 and 19, I was hearing some noises about low carb. There is a body here in Australia called as CSIRO, which published a book on low carb recipes and low carb diet to help patients lose weight. I started promoting it without knowing much about it. But in late 2020 and 21, I read a paper from Dr. David Ludwig's group from US. And what he showed in his study was he divided the patient into 3 groups. So this was a game changer study for my own learning. So high fat group and low protein and low carb. Now, second group was high protein, low carb and low protein. And the third group was high carb, low fat and low protein. And it was done in healthy volunteers and about for, I think, 12 to 16 weeks. He showed patients who were on high fat diet, and he manipulated the diet or energy intake in a way that their weight did not change, because losing weight is a confounder. And he showed the patients who have high fat diet, their basal metabolic rate increased. Just to explain to the viewer, the BMR or basal metabolic rate is the one energy we consume while we are not doing any physical activity. Like while sleeping, our heart, our brain, our intestine, they all need energy. That sort of is basal metabolic expenses. So if you increase your BMR, you will lose weight. So I was very influenced by that particular study, and I was a victim of metabolic syndrome as well. I was diagnosed with diabetes with A1C of 6.7 at age 40 when I was in Canada. And I was doing everything right, following the guidelines, taking metformin, and I was always an avid exerciser. And my A1C was stuck at 6%, taking metformin 2 grams. But my blood pressure seems to be going up, and it required 1 drug, and 2nd drug, and 3rd drug. My waistline was growing, and I'm feeling more tired, and I developed sleep apnea as well. So I was struggling with my own personal health, following guidelines, but I was not getting better. And at the same time, I had a very difficult patient started on peritoneal dialysis, and I mentioned that case in my talk in the Low Carb Sydney. And this lady was landed on dialysis because of a very resistant blood pressure. Blood pressures were in 200, and she was on multiple treatment. Despite it, we could not bring her blood pressures. She was weighing 120 kilos. So influenced by Dr. David Ludwig's paper, I changed my diet. And I went into a 60 to 70% fat diet, some moderate protein. And I cut back my carbohydrate intake to about 10 to 15% of my overall energy intake. I applied a freestyle Libre sensor around the same time as well. My breakfast used to be home-cooked dalia or wheat porridge. And first time I looked at my blood sugars after I had a wheat porridge was in the range of 13 to 14 millimole, which is like 250 to 300 milligrams. I was shocked. This happened within first 30 to 60 minutes of eating porridge. Since then, I never had porridge. This is 4 years ago. And I changed my diet, looking at what foods makes my glucose to go up. And I still practice an ovo-lacto vegetarian lifestyle. And my A1C is now 5.5, just near the normal, and I'm off medications. But my blood pressure does perpetuate. So it looks like I had irreversible microvascular damage, which perpetuates my blood pressure. And that case, again, I had left with no option. She had recurrent hospital admissions for high blood pressure, going to the ICU. I put her on low carb diet. She was eating fish and meat. So I said, you can have fish, meat, eggs, poultry, some beans, but avoid wheat and rice. Vegetables are okay. Limit to 2 meals a day and do some time restricted eating. She lost astonishing 35 kilos of weight. and in a dialysis patient is a big achievement. With my own personal health, I lost about 10 kilos of weight, and everything else got better except my blood pressure, which is better controlled, but I still require 2 medications to control it. Since that experience, I started practicing slowly into my practice, and I was hugely rewarded. A lot of patients reverse their diabetes. A significant proportion of patients could come off insulin, including my 80-year-old mother. She was on insulin for some time. She lives in Delhi, and she has extremely resistant diabetes and hypertension. And she developed diabetes at age 35. Now she's turning 80 early next year. So she could come off insulin by adopting a time-restricted eating and a low carbohydrate approach.
So that was quite an explanation. So that means, if we summarize, the dietary guidelines are abject failure. Would you agree to that?
Yeah, absolutely. I think as the different authors has been explaining, in the 1970s in US, they changed the guidelines and put up a pyramid approach. And I think we blindly adopted that guidelines in India as well. And I think we did few major changes in our diet with respect to our country. One, we were using traditionally ghee as the cooking medium or cold pressed seed oils. But the introduction of these processed oils, which are known to be inflammatory and causing insulin resistance, was a big change in last 50, 60 years. Promotion, I remember advertisement of Safola, it's a heart healthy oil, which is on the contrary. And secondly, there's a large introduction of wheat. Earlier, we were using more millets in our diet rather than wheat. Wheat used to be a luxury. But later, 1950s, 60s, and 70s, we were actually starving. And you may be aware of that they hybridized wheat, made it more resistant to pesticide and weedicide, and to the weather to increase its yield, which increased the content of the gluten. They were using a lot of glyphosate for both wheat, protecting for wheats as well as for maturation of wheat. So I think combination of using more seed oils, more introduction of wheat products, and then we have extended eating hours from morning to night. So I think this changed our more stress in our life, lack of sleep, and poor physical activity. So I think combination of factor that India is looking at a medical metabolic disorder tsunami.
Now, I want to come to a very, very important question as a nephrologist. So you have seen the application of low carb in reducing the blood sugar numbers, getting people off. What improvements have you seen in creatinine level, eGFR level? Have you seen significant decrease in these? Have you been able to get the creatinine or eGFR back to normal?
So I will quote my personal experience first, which is unpublished. So in last 4 years, I've been very aggressive in pushing lower carbohydrate approach in my patients. A majority of my patients, by and large, 99.9%, I would say, are Caucasian. There is very small percentage of indigenous patients, and some of the Indian population who lives here are my patients. I do not go for extreme restriction of carbohydrates, which are like ketogenic approach, carbohydrate less than 20 grams a day, which is hard to achieve and it's not sustainable. Plus, these patients have a lot of comorbidities. So, and there is a huge change in the culture. So I prefer a more liberal low carbohydrate approach, which is like carbohydrate restriction between 50 to 100 grams. But even having said that, any drop in carbohydrate intake, I see a gradual improvement overall in metabolic health. My patients easily lose about 5 to 10% of their body weight. So when they lose body weight, they lose also fluid weight, and their blood pressure comes down. And then I can de-prescribe medications, particularly diuretics or fluid pills in general language. And once you cut back their diuretics, I found their kidney functions improving. If they're not improving, at least they get stabilized. I may have to reduce the other blood pressure medication. But although it varies from case to case, I see a wide range of kidney disease starting from stage 1 up till stage 5. So these different classes of CKD or stages of kidney, they behave differently. They have different risk factors. So the approach differs from case to case. But by and large, I practice a liberal low carbohydrate approach, moderate protein, and healthy fat component for satiation and reducing their craving. If you look at the literature review, there is a GP in UK called as Dr. David Unwin. He published a study in patients with diabetic kidney disease, with stage 1 kidney disease, very mild kidney disease. And he showed there is an improvement in the GFR and significant proportion of patients could remit their diabetes. There is a randomized controlled trial in diabetic CKD stage 1, 2, 3. They showed either no change GFR or improvement, but no worsening of the GFR. There is a large Cochrane review, which is a very respectable body, which again produced a meta-analysis stage 1 to 3 CKD, and they showed either a positive or a neutral effect of low-carb diet on the progression of chronic kidney disease.
Fine, thank you. I just wanted to know very specifically how much for example, I had one CKD client where it lowered from 3B to stage 1, stage 3B to stage 1. So very, very successfully with the application of fasting as well as very low carbohydrate. So very, very curious to know from a nephrologist point of view. Yeah, Anup, you want to ask something?
Yeah, when it's glad to hear that Dr. Alok's version of low carb is pretty close to what we do, and for right reasons, of course, because it's keto is pretty difficult to adhere to. Now, when it comes to low carb, the general perception is that protein damages kidney. General perception, if you're taking high protein, I don't know what high is, but if it is more of protein, then your kidney will be damaged. So what is your response to such, storytelling, I would say?
I want this to be in two contexts. One is, does high protein diet damage the normal functioning kidney? One, and does a significantly higher protein diet, significantly higher from whatever baseline they were taking in CKD patient, is it harmful?
So as I explained earlier, we got 1 million nephron. Each nephron has a head called as glomerulus, and there is a filtration of blood within that glomerulus. If you increase your protein intake, there is a higher filtration within the glomerulus, which is physiological, which is normal. Now, in someone with normal, healthy kidneys, increased protein intake does increase GFR, which is physiological, and there is no evidence to support that higher protein intake related increase in GFR is damaging to the kidneys. But there is a caveat. You have to understand what is normal and healthy. So experimental evidence, as well as there are good studies which have clearly shown that there is no short-term or long-term damage to the kidneys if they are normal and healthy in view of increased protein load. Now, coming to the chronic kidney disease, we divide chronic kidney disease into 3 broad categories. Mild kidney disease, which is GFR up to from 60 to 90, which is stage 1 and stage 2. Then stage 3 kidney disease, which is moderate kidney disease, GFR between 30 to 59. And then the severe kidney disease, which will be stage 5 4 and stage 5 dialysis or pre-dialysis, which is GFR less than 30. So whatever data we have, stage 1, 2 to 3, there is a very little evidence that higher protein intake damages kidney or leads to higher progression of the chronic kidney disease. This is documented evidence, and there is a large Cochrane review on this as well. Now, when it comes to stage 4 and 5, which is severe kidney disease, and mind you, as I said, nephron keep dying, pushing their work on the remaining one, overloading the remaining nephrons. When you are in severe stage of kidney disease, you are probably left with 250,000 nephrons in each kidney, which is a quarter of the normal nephrons. So these nephrons are under huge stress. So technically, proteins can increase their GFR and the of disease. So in these group of patients who have severe kidney disease, I tend to not go over more than 0.8 gram per kilogram. But therefore, the nuances, it depends on the quality of protein you are eating. It depends on what type of protein you are eating, how much protein is getting absorbed and going into the circulation and effectively causing increased GFR. Then in this stage of patients, probably plant proteins are safer than animal proteins. Plant proteins have an alkaline nature, while animal proteins have an acidic nature, which could cause increased requirement of bicarbonate, which is generated by kidneys alone. So when kidneys are sick, like severe kidney disease, you don't want changes in the blood pH. You may need more bicarb supplementation. So in severe kidney disease, I try to restrict to 0.8 grams per kilogram, preferably plant-focused or plant-dominant protein intake. And I could see that Dr. Thomas Wemby is coming on your platform on Sunday. He has done a lot of studies on keto diets, low-carb diets in PKD patients. He recently published a study, keto PKD, and which he showed that the GFR actually gets better on keto diet. It's a randomized control diet, which is gold standard. So in severe form of CKD, I tend to be cautious. I very closely monitor their numbers, their electrolyte, their acid base, their protein losses in the urine. If there is high amount of protein in the urine, which means these nephrons are hyperfiltrating. So I'm a bit cautious in that group. I don't ask my patients to go overboard or become carnivore. But I think moderate protein intake is quite reasonable, and it's safe to, and this is my personal experience as well as whatever evidence we have.
I think moderate protein, when you say, is 0.8 gram per kg body weight?
Yeah, 0.8 to 1.2 gram per kilogram. The definition keeps changing.
Now, I'll tell you, you know this, in India, the consumption of protein by the average population is somewhere at 0.5 gram per kg body weight, which is less than that recommended for a CKD patient.
Yes, absolutely agree. In general, we are on a protein restricted diet. And unfortunately, when I did my nephrology in India, starting 2003 to 2006, spending time at Apollo Hospital. Then I was a junior consultant for 2.5 years before I went to Canada. And I saw this practice of nephrologists restricting protein. These patients are already on a restricted protein diet. By convention, and if you stop their dal, lentils, and beans, they become ultra low protein diet. So what you see in these dialysis population, if you go to any dialysis center, these patients are very frail, they are sarcopenic, they are malnourished, they look like dead people. If you go to any dialysis unit, it's a very sickening look and very depressing atmosphere. These patients can barely get out of their bed and their protein are restricted. I remember Dr. Vijay Kher, he's a top nephrologist in Delhi NCR, and he was one of my guide and mentors and teachers. He was the only one who used to say, never restrict protein. I'm talking about 2003.
That is how it is, I used to, I many times in social media I say that the protein we take is less than that is recommended by Kidigo or whatever organizations, 0.8 gram or even 0.6. We take less than that. So that is how it is. How about these protein powders which are recommended? What we see is generally in protein powders, it does contain a lot of carbohydrate, paradoxically.
Yeah, even here I see inpatients are given when they are sick, they are malnourished, catabolic, they're given protein supplements. They come as a package. And most of the protein packages, they have at least 20 to 30 grams of sugar, some even higher per serving of 250 mils. And nature packages proteins with fat in animal products like eggs or meat or nuts, or like beans and lentils. They are proteins and carbohydrates, complex carbohydrates. But the man has produced a protein drink with free sugars, which have very high glycemic index as well as glycemic load. So I think this is a recipe for disaster, and I do not promote this. I believe in more whole food approach, which gives you a pleasure of eating and satiation as well.
So that remains little paradoxical. I always see that people are restricted for protein, but they recommended this tinned protein, which is not only costly, but contains more carbohydrate, and which is going to lead to more disaster in the sense their blood sugar, blood pressure is not going to be controlled, and they are all going to probably worsen.
Yeah,
Anup?
absolutely agree.
I think there's one SGLT2I, the latest.
What is your view on that?
Yeah.
So I have a colleague, Dr. Karen Dwyer. She's the director of nephrology at a very reputed Royal Melbourne Hospital. And we did collaborated, and last year there was a paper published in Diabetes Obesity Journal. So if you look at Karen Dwyer and my name, it's a combination of SGLT2 and carbohydrate restriction. It was predominantly Karen's work, but she was gracious enough to involve me and Penny Fig Tree. Penny is coming on, I think, Sunday. So we three are the author, but it's predominantly Karen's work. And she did a beautiful presentation on low carbohydrate diet and SGLT2 inhibitor combination in the low carb series last year, which is freely available on YouTube. My personal experience has been very good. SGLT2 inhibitors are also a game changer medication in the field of nephrology. You may be aware of drugs like ACE inhibitors or ARB, which reduce the hyperfiltration in the nephron and protect them from further injury. SGLT2 inhibitors also reduce hyperfiltration and are complementary to ACE inhibitors and ARB. So SGLT2 are now standard of care in nephrology, irrespective of diabetes, because they slow down the progression of the kidney disease. They were primarily an anti-diabetic drug. They were the first drugs for diabetes, which actually improved insulin sensitivity. You're losing up to 80 grams of glucose in the urine. So it changes the insulin glucagon ratio. It drops the insulin level and increases glucagon. It changes the substrate utilization from carbohydrates or glucose to fatty acids and increases the ketosis. So these drugs fully, they are complementary to a low carb approach, but there is small risk of metabolic acidosis or ketoacidosis when you combine a low carbohydrate diet and SGLT2 inhibitors, but the risk group would include someone who has type 2 diabetes. So non-diabetics, SGLT2 inhibitors plus low carb, very low risk. But if you're a diabetes, the risk of acidosis, ketoacidosis double up. If patients become acutely unwell, like they have nausea, vomiting, diarrhea, so volume contraction, they are undergoing a surgery, or they have acute infection, their insulin resistance go up, they may become insulinopenic. That's the risk factor to increase the acidosis. So I tell my patient, if you are sick, don't take SGLT2 inhibitors. So that's important to remember. The risks go up in diabetics. Plus, if you're acutely unwell, there is a third entity called as LADA, so latent autoimmune diabetes of adults. So some estimate up to 10% of all type 2 diabetes patients who are diagnosed may have LADA rather than the insulin resistance type 2 diabetes. And if you put patients on low carb plus SGLT2 inhibitors, you may see increased risk of ketoacidosis. So I tell them, keep yourself well hydrated. If you are sick, don't take SGLT2 inhibitors. But I think they have a profound role in the management of chronic kidney disease, particularly protein-associated chronic kidney disease.
But how does it go well with low carb? All your patients are going to be having diabetes, most of them at least. So does low carb and SGLT2 go very well? Or how about low carb and how about SGLT2 and ketogenic? So these are two different combinations, low carb and SGLT2, ketogenic and SGLT2.
So as I said, I don't think any of my patients is on ketogenic diet. They're all in liberal, low carbohydrate diet. What I'm saying in someone who has diabetes and chronic kidney disease and is practicing low carbohydrate approach like 50 to 100 grams per day, on top you're on SGLT2 inhibitor, it does increase the risk of ketoacidosis in 3 situations. One, they are acutely unwell with infection, volume contraction, or surgery, or if they have underlying LADA, or their kidney disease is very advanced in progress. So in these group of patients, I remain cautious.
Fine. Thank you. Anup, you want to ask something? Or
yeah, it's all done, almost all done. Just to for benefit of viewers, maybe in posterity also, what numbers would you put for protein per kg body weight for a normal person, for a diabetic, and for a patient with, let's say, CKD early stage?
So for normal healthy population and stages, diabetes with or without CKD, and CKD stages 1 to 3, I wouldn't restrict protein intake. See, how many of us actually measure how much protein we are eating? I go with a whole food approach, and I will prioritize protein for my muscle health, satiation, reducing my craving. So I think anywhere between 0.8 to 1.2 gram is a very safe range. But when it comes to advanced CKD stage 4 and 5, particularly with high proteinuria, I would be cautious and would not recommend going above 0.0 grams per day until we have more data. Now, having said that, I forgot to mention one thing. The drugs like SGLT2 inhibitor we just discussed, ACE inhibitors and ARB, and drugs like spironolactone, they all reduce hyperfiltration in the kidney. And when you are on these drugs, it protects the nephron from any potential increase in the hyperfiltration from high protein intake. Studies were done in older times, which showed some damage from the protein. And those studies, these patients were not on these drugs universally. Things have changed. When are you on these drugs? You are by and large protected from hyperfiltration injury induced by protein intake.
Thank you. Your final message to India.
I think there is hope, and both of you are doing a very great job. I would compliment your work and congratulate on organizing such a beautiful conference. But I think there is hope. And I would recommend that reducing ultra-processed carbohydrates, particularly wheat products, in my personal opinion, is important as number one. Number two, we should all practice time-restricted eating and fitting with the aligning ourselves with the sun. Dr. Sachin Panda has done a lot of work in circadian rhythm, and he showed if you just to stick to sunlight hours without changing anything, you can improve your metabolic health without changing any diet. And 2 meals a day is more than enough. If you frequently eat, you increase your oxidative damage through your mitochondria. So if you reduce the number of times we eat actually 5 or 6 times a day now. If you restrict to 2 large good meals morning and evening, you reduce injury to your mitochondria, which will have a downstream effect. Third is importance of exercise. We have a epidemic of physical inactivity. I was reading a review earlier this week to prepare for this talk, and the name of the review was Exercise, a Polypill Against Chronic Kidney Disease. And they showed with exercise and physical activity, improved GFR, reduction in proteinuria, reduction in cardiovascular mortality. So yoga, pranayama has been part of our life for like centuries and millennia. So we should do regular physical activity and good sleep, reducing stress, meditation. I think they will all add up to improve our health.
Thank you. Thank you very much,
Thank
Doctor.
you. Thank you,
Namaste
Doctor.
from India.